Good evening, Vikram sir. I've already joined.
कैची कहाँ रख दी?
Hello. Sir, you're audible on the phone, but you're not audible here on the Zoom. That's why I messaged you. Sir, who is the moderator?
Sir, voice is not clear.
So is it audible now?
Yes. Now it is audible.
Yes, sir. Yes.
Now it is audible.
So I request all of you to put your microphones off as well as the cameras. So here we have Dr. Kane with us. So Dr. Kane himself is a very good sports person. He's working as a sports medicine consultant with CRPF. He has served a lot across the country, from Kashmir to the Northeast. He has worked with the hockey team, men and women, at Rio Olympics. He worked with Indian police contingent at World Police Games. And he himself is a very good football player and a tennis player too. So I introduce to you Dr. Kane. And Kane, this will be good enough if you can introduce yourself, because you are such a decorated policeman as well as a doctor as well as a sports person. So this is very difficult to concise your introduction in few words. So I would request you to introduce yourself, and then you can go along with the scientific talk too. Thank you.
All right, sir. Good evening, everybody. Thank you very much for the kind words, sir. I hope I'm audible.
Yeah, you're very much audible.
I hope I'm audible, yes.
Yeah.
So I thank you, Dr. Vikram, sir, first for the opportunity to interact with a lot of people. And today we will be talking. I mean, it's a very good initiative. We started because of the lockdown, a lot of Zoom meetings, and now at least people can sit in their homes or the offices and interact and get to learn from each other. So uh, today I have been given the topic of overuse injuries around the knee joint. So I'll try and focus and keep it as a little bit practical and clinical approach, which is available to everybody. So I think the chunk of the participants today would be physiotherapists, sir, and
Yeah,
maybe
most of them are physiotherapists.
so we'll try and keep it around that direction for them. So things that they normally not would not be getting from their books, but more of practical experience. So sir has already said about me. Unfortunately, today is one of those rare occasions where I did not put any an introduction slide on myself. But just to let you know, sir calls me Ken with love. Otherwise, my full name is Dr. Kenjom Ngomadir. And I'm an MBBS from KGMC Lucknow. I've done my pediatrics from Safdarjung Hospital, then accident trauma emergency medicine from MS Ramaya Medical College, Bangalore, way back. And then I did sports medicine from NSNIS Patiala and Government Medical College, Patiala. Sports medicine was not a branch that I wanted, to be very honest, because when we did it, I did it in 2007. The concept was not very much there. Now the awareness, and because of social media and awareness, people are really getting to know. And I think this is the in thing now, to be a sports medicine specialist or a sports physiotherapist, is because everywhere else you can earn money, but this is where you earn fame and liking and respect, and you get to see the world, etc., etc. For me, I fought a lot. In fact, I rejected the department's request for 1 year. In the department, you get to go for study leave after 5 years of service. And then normally you get to choose your branch if it's available, like pediatrics. So being in CRPF paramilitary forces, they said we don't need pediatricians, we already have enough. So I would have liked to continue with pediatrics or accident trauma emergency medicine. However, and I was serving in Kashmir's anti-militancy and everything. I've served the length and breadth of the country. And but I went and did sports medicine because having a sports medicine, being a sports man, basically in the department. I mean, even in college, everybody knew there were only 2 places or 3 places you could find me, either in the hospital, in the library, or in the ground, training or practicing or playing. So, but in the long run, it's turned out to be good to me. My batchmates tell me a very beautiful thing. They said there are so many nephrologists, there are so many orthopedicians, there's so many everywhere else, but only few get to go to the Olympics. So it's because of sports medicine that actually I was able to go as the team physician to both the men's hockey team and the women's hockey team. That's again a first, to be a doctor of two really good elite teams. And I was fortunate enough to be selected for that. And I was able to go to Rio. And there have been so many other events and championships. But let me tell you one thing. Basically, the talk that we're going to do today, I feel there's a lot of work behind closed doors. As you grow, initially it's with everybody. You see every physio or doctor who tells me, sir, mujhe IPL mein kaam karna. I mean, it's great because that's where you get the media, the thing you can, it's very good to put on the social media face and all. But let me tell you, the work is done at the ground level. And gradually, once, like most people are trying to go up, actually I'm going down. I'm going backwards. I'm going down and working more at the children level. I'm working more at the grassroots level. I'm working more, and I'm working a lot on prevention, because the more cases, initially you want to get the cases, but once you get a lot of cases, you feel, oh God, I can prevent these diseases, so we do a lot of education. So I think this is what Dr. Vikram and his team also is emphasizing on today, is basically we want to focus a lot on prevention. So I think the entire talk today will be more on the common overuse injuries around the knee joint, but we are going to focus on how to prevent. So once you are aware, then you will be able to, at the grassroots level also, you'll really be able to help your athletes and your players. So can I start my talk, sir? Screen share?
Please.
Allow for screen share? Okay, here we go. Once again, good evening, everybody. So we are going to talk about overuse injuries around the knee joint. So let's come with a basic definition of what is an overuse injury. So the classic definition would be an injury of the musculoskeletal system that results from the combined fatigue effect over a period of time beyond the capabilities of the specific structure that has been stressed. I will explain this more in a normal language as we go by, but this is the bookish definition. An injury of the musculoskeletal system that results from the combined fatigue effect over a period of time beyond the capabilities of the specific structure that has been stressed. These injuries occur when several repetitive forces are applied to a structure, example, muscle or tendon, each less than the acute injury threshold of the structure. So basically, if I give you an example, normally when we look at overuse injuries as undergraduate students, for me, it was always like related to stress fractures. You know, we're looking at bone and joint. It was very little to do with muscle injuries, especially during the MBBS, because we deal more with medical issues, surgical issues, and the acute injuries, these are traumatic injuries. So this is a very important subject. I hope that I'll be able to do some justice to it. Okay, so we look at overuse injuries can occur to the following structures: the tendons, the muscle tendon structures, soft tissue compartments like compartment syndrome, periosteum cartilage, which is the covering of the bone, which leads to shin splints, leads to stress fractures, and bursae. In fact, I look at bursa should actually be more on the top, because I think the first thing that overuse is a lot to do with bursitis. If you have done a little bit of studies, if you are graduates and postgraduates in sports especially, you know the bursitis is actually very common and really difficult to treat also. And of course, we have nerve tissues, mechanosensitivity, and of course, we come to the bone with the stress fractures. Signs of overuse or inflammation include swelling, which may be unnoticeable sometimes, warm to the touch, redness, and of course, impaired function of the part. You're all very aware about it. So I'd just like to note here often that the first sign may be stiffness or soreness, especially in the morning, which may disappear with a warm-up. Continued activity may cause continued damage, and the pain will last through and past warm-up, and maybe even worse after an activity is finished. So we look at generally the 4 stages of an overuse injury. So the 4 stages would be: the first stage is the discomfort disappears during warm-up. You know, someone gets up a little bit stiff, and then you as you go to the ground, you're warmed up and you feel it's okay. That's what your patients will always tell you. Your athletes and your patients will tell you that. And the injury doesn't really worsen. It becomes okay. And then after playing, once you're resting, you're a little bit stiff. Maybe if the individual knows how to stretch and do some icing and some stretching, they become okay. Then they're stiff in the morning the next day. But once they're warmed up, they're okay. So that's really stage 1 of the disease, overuse injury. Then the discomfort may disappear during warm-up, but reappears at the end of an activity, immediately after the activity, or when the activity is a little bit heavy or hectic. Activity may continue at a modified pain-free level. Now, discomfort that gets worse during the activity must immediately cease and manipulate when we have to manipulate training. Pain and discomfort all the time. And of course, the activity must immediately cease. This would be the advice on the 4 stages of overuse injuries. So what causes overuse injuries? Most importantly, the lack of appropriate muscle strength or endurance, poor core stability, load management, very poor load management. Because the problem is most people, or the coaches mainly, don't have at the lower level, don't have a concept of sports sciences. They just think that loading more and load basically means giving more and more exercise, more and more work. Like you watch in the movies and all, you'll see that some of the movies, especially I can't remember the picture, but there was one movie where Shah Rukh Khan was like, you know, he was not able to do well. So one of the matches before that, he was practicing the whole night. After he got motivated by the coach's talk, he actually trained the whole night in the stadium alone. And he was doing all those kicks and running and hitting against the wall. And the next day he was able to play a game, which, you know, it's such a misconception. So if you're playing the whole night and you've not rested, obviously you'll not be able to play in the morning. But that's because of the misconception. So it comes down to load management. And I have made this in block letters because I think this is the most important factor. Everything works around this. And muscle imbalance, strong tight muscles versus the weak stretched muscles, inflexibility and very poor agility and mobility, malalignment or biomechanical issues like flat foot, squinting, patella, etc. Training errors, most common of course is the too much, too soon and too quick. Again, see, that comes to load management. Faulty techniques, obviously, there are a lot of faulty techniques that can cause poor overuse injuries, and incorrect equipment. So, like I said, we talked about load. What causes overuse injuries? So just look at this slide. If you look at this slide, you'll see that you can easily see there's a Greek mythology where the kid, when he's a teenager and adolescent, he's carrying the calf, and now this calf becomes a slightly bigger uh, bull. But you'll see that this boy also has built up his muscles over the period of time. So it's proportionate to the size of the bull. And now the bull has really become big, but this boy also has come almost, the body is like Hercules or Dwayne Johnson, if you see, The Rock. So this is basically, this picture shows even at olden times, they knew this is how you need to manage your load. So you grow and then you take the load accordingly. Like I said, unfortunately, at grassroots level, the sports science is very poor. The most commonest overuse injuries is because of poor load management. And this is the same slide. So we just come to overuse injuries. Somebody is fiddling with their phones, and I'm getting all these signs on my. Thank you so much. Please don't fiddle with your phones because I'm getting all those scratch marks on my screen. Overuse injuries. Biological structures like the muscle, tendon, ligaments, bones, they adapt positively or negatively depending on the level of stress, that's load that is placed on them. Positive remodeling. Repeated stresses that are less than the tensile limit of the structure, provided there is an adequate time period between stress applications. Basically here it means recovery. When you have sufficient amount of time in terms of nutrition and recovery, then you will have a positive remodeling and you will not go into overuse injury. Then of course you look at injury which causes negative remodeling. Any single stress beyond the tensile limit or repeated stresses that are less than the tensile limit with sufficient time period between the stress. So I'll just exit the stop share, and then because somebody is fiddling with the phone and they're scratching all over my screen. I think we will need to tell people to not touch the screen too much because sometimes it gets pressed, and I think I'll reshare the screen. Okay. So I have this very interesting analogy, which I like to use when we talk about overuse injuries. You look at this rope. So this is a normal rope. So imagine this to be our tendons and our muscles. And this is what happens when you have overload injuries. You see, it starts with maybe 1 fiber, 2 fibers, or 3 fibers get a break. And then you look at this. This is how sometimes our tendons and our ligaments and our ligaments generally do not go into overuse. Ligaments are generally always acute trauma because they're very, very strong structures. But yes, definitely we're looking at the soft tissues. This is how basically we would have the damage. So what happens is sometimes if you get sufficient rest, even after a major injury, even if it's grade 3, and then you get it time, it tends to heal and remodel very well. So this is an interesting analogy which I like to use when we talk about overuse injuries. All right. So the variables that have been identified as risk factors are training, of course, like I said, load, anatomy, and biomechanical factors. There's another interesting slide which I had is, we always say, because we're talking about the knee today, तो हम लोग कहते हैं कि तुम्हारा दिमाग घुटने पे है क्या? See, I found an X-ray which had a brain on the knee, just to make it interesting. All right. Overuse injuries. Again, training would be excessive, maybe running distance, excessive jumping, rapid increase in weekly running distance, too high of training intensity, related training variables, including the running surface and shoes that are chosen to wear. And if you look at the anatomic and anthropometric, you see the longitudinal arch height, like pes cavus, pes planus, range of motion, muscle imbalances, soft tissue restraints, leg discrepancies, and of course the alignment abnormalities of the lower limbs, like the Q angle, the genu varus valgus, patellar position, patellar alta, baja, You must have all read that. Increased lordosis, femoral anteversion, tibial torsion. And of course, biomechanics would be kinetic or rear foot kinematics variables, abnormal large external or internal stresses that are outside of the physiological normal range of motion, and magnitude of impact forces, the rate of impact loading, the magnitude of active propulsive forces, and the magnitude of knee joint forces and moments. So again, when we talk about load, I'll just spend some little bit of time on this slide. So if you look at any movement that you need to work in sports, so that's what we said was training at the grassroots level, that it was again with the load management. So we all work on endurance, we work on strength and power and speed, but this is a foundation of movement. So if there is not sufficient recovery, there is not sufficient, you grow with endurance, you grow with strength, you grow with power. So you have a lot of, say, little children who are really good with sports, or you're really good with sports, and suddenly you get a new coach and he says, this child is very talented, let's just put him on training and training and training. So for example, if you watch, say, tennis, say for example, or badminton, so suddenly you have so much of overtraining, say like overhead shuttles, or the coach makes you do too much of smashes today, or too much of tossing, third court tossing, because your tossing is weak. So you end up doing so much and you're not able to take the load. So you're looking for an injury that way. And the idea is, that's why you look at this pyramid of endurance, strength, power, and speed. So whenever we go into a training load, it's like in that first slide, in that slide which I showed about the Greek god taking the calf and to cow and then the bull. So we have to progress training basically and load management very gradually if we want to prevent the overuse injuries. All right. Now look at the essentials of assessment. And this is not just for overuse injuries, but this is for each and every disease, each and every ailment or illness that you would be treating as physiotherapists and as doctors. So even right when we were in college, we never knew then at that importance at that time. Maybe when our second or third year, we straight away wanted to jump to, clinical examination and treatment. We did not know the value, but as we grew and grew in time, in the years, we've realized until today, I get a lot of important points for which helps us plan the treatment plan, also including the management or investigations based on history. So history is the key. Always listen to your patient and ask key questions. And of course, training and competition in history is very, very important. Training and competition history of the specific sport, of that particular sport, the discipline of that sport. Because like, say, let's just look at cricket, say for example, he says, I play cricket. No, you need to go a bit deeper. He says, I'm a fast bowler. Yeah, at how many kilometers an hour is he bowling? Is he a front on bowler? Is he a side on bowler? So if you can look at his mechanics too, and how much of bowling does he do, how much does he bowl at the nets, how much does he bowl in the competition, so, and how much training he does before and after the bowling, that's again very important. Same as with badminton or tennis. How much does he do serving drills? How much does he do forehand drills? How much does he do backhand drills? And which is the dominant limb? So all these things are very important. And recent changes in training technique would be maybe recent changes in training technique. It happens. Training surface shoes, road, track, site, stage of current training cycle. As in they basically stage of current training cycle basically means, periodization of training. Where he's in the mesocycle or the macro cycle, if he's in pre-competition, competition, or post-competition, and whether the next important competition is coming up soon. Then you review the systems as in the entire system, like the cardiovascular system, the neurological system, right? The abdominal, the gastrointestinal system, the neurological. So you have to also review all the other systems too when you're managing your overuse cases. I believe that the first contact with your patient, you should always spend time on history, and then of course examination. Then history of medical comorbidities or previous injuries, and evaluation for endocrine disorders or nutritional deficiencies or nutrition deficits. Of course, then you come to physical examination. You definitely evaluate for, the biomechanical factors which I was talking about before this, and of course, if they've had any previous history, and then of course an examination, then you do a leading examination. We palpate for crepitus and pain, tightness, functional and strength training, definitely. Before I go further, this is a very interesting surface anatomy. If you can see, I think most of you have got this picture. If not, if you can just put this in your picture, you can immediately understand that when you just look at the examination from a very superficial view, you can get a general idea where the individual would be having the pain or what the cause of the pain would be. So if you look at this slide here, so if you look at the outside of the knee, you know, we can have pain on both sides of the knee, and then you can have meniscus or arthritis around this area. It's here it's infrapatellar. So it can be pain just below the knee. It could be Osgood-Schlatter, osteochondritis dissecans, jumper's knee, patellofemoral. This is what we will be talking more about today. And around this area would probably Syndig-Larsen. And of course, you'll have bursitis, chondromalacia patella, patellar tracking. And here would be suprapatellar quadriceps tendinopathy, right? If you look at the side, the individual goes up this area, you can think in terms of IT band syndrome. So even when you examine, it's always good to, before you start examining, just ask the individual to really pinpoint with his fingers or a pencil where exactly his pain is there. And sometimes they say all over the knee, but you say, no, where is the pain most severe? Or where does the pain originate and where does it transfer to? I'm again getting somebody playing with the screen. All right. Functional assessment, again, please do check for. When I say functional assessment means you do bilateral and single leg squats, say, of the individual. Or if the individual is a badminton player, you can just make them do the badminton drills. If it's a footballer, you can do the different movements, especially the movements where he's feeling the pain, you know, and you can do the various functional assessments like the bilateral single leg squat, step down, drop jump. These methods can identify hip, knee, ankle malalignment, hip and core muscle weaknesses, of valgus movements like knock knees during landing, etc. Excessive foot pronation, knee valgus, femoral internal rotation, lateral trunk deviation, and pelvic tilt anteriorization, etc. And like laboratory studies, normally for musculoskeletal overuse injuries, it's not always necessary unless you have certain comorbidities. Like there have been cases when we thought in terms of overuse injuries, but then when I got the serum uric acid of individual, I found the uric acid was like shooting all over 15, 16 above, and then that's why there was so much of inflammation and swelling. And I was thinking in terms of an ankle sprain or something like that. Once treated him for the gouty arthritis, the patient was relieved immediately after the second dose of the tablets. So I think that's why the history is very important. And sometimes, yes, you should also have a lookout for medical issues too. And of course, imaging is very important. I think in for overuse injuries, imaging is very, very important. And a lot of diseases like Syndig-Larsen or Osgood-Schlatter, you can actually, plain films would really help you in AP views and lateral and axial views, especially for bipartite patella, osteoarthritis, loose bodies, occult fractures, tumors, you know, and like I said, apophysitis, avulsions, and MRI, magnetic resonance imaging, of course, all the degenerative changes, cartilage fissuring, thinning, subchondral bone, marrow edema, subchondral cyst. And the latest now to go, which is less invasive, and especially when you want to look at the bursae, at the tears, at different grades of tears, and how much is the level of tear, how much millimeter tear is. The dynamic musculoskeletal ultrasound, which very few radiologists are doing. If you can find someone who is doing that, then you should send them rather than for MRI or an X-ray, because this is basically, there's no radiation here when you talk about ultrasound. So it does really help. And ultrasound helps in identifying the focal changes, you know, in the tendon architecture and subtle changes in tendon vascularity. So it's low cost, there's no radiation, and it can help us in also not just planning the management, especially with athletes, because normal patients, it's okay, they take the time. But for athletes, the first question is, when can I return to training? When can I return to play? When can I return to competition? So these sometimes then, of course, these imaging is very, very important to help you not just treat, but manage, but also to plan the return to play. Of course, you have other supplementary assessment tools like you know, the gait analysis, anthropometric evaluation for hamstring quadriceps flexibility, isokinetic testing, instrumental Q angle measurements, dynamic landing and dynamic electromyographic measurements, functional assessments tools, etc. Okay, when we look at environmental training surfaces and shoes, hard or even surfaces, shoes and orthotic devices Of course, we look at climatic conditions, too hot, too cold. Sometimes when it's too cold also, individual is training in cold climate, doesn't really warm up properly or doesn't cool down properly. Or in extremely very hot conditions, they don't warm up properly. They don't, again, cool down because anyways it's very hot. They feel I'm flexible and all. So when suddenly they have these sudden changes of climates, these can also cause uh, injuries. So we need to look out for that too. And we most of the people don't look at the social role and the social support system, which is so important. The clinician must remember, whether you're a physiotherapist or a sports physician or a doctor, the clinician must work in cooperation with the patient, family members, athletic trainers, and coaches to achieve a better outcome. Like for my elite athletes, for example, if they're children, the parents are definitely coming, the coach is definitely coming, the fitness trainer is definitely coming. If they have a and the of course, like the physiotherapist. So we all on the same page. The parent is going to pay for your fees, and for, say, if you're going any other further testing or imaging, the parents is very important. They need to take care of it, especially most of the overuse injuries. If you look at Osgood Schlatter, Cindy Glassen, and all these are almost children and the adolescent, and they don't have their own payment options. So it's very important to take family members also, because it's also the psychological aspects of injuries. And of course the trainers, because they're going to plan your training. You work in the clinic separately, and then let these people go back and do a separately different kind of training load, which is not supposed to be done. And then all the work that you've done in the clinic will go to waste, and they will think that it's your fault that actually the patient is not improving. So it's very important to have everybody on board. Of course the coach, because the coach is the most important person who gives the training load, and what kind of training load. It's important that all involved are aware of the nature of the disease, process, treatment, interventions, probable outcomes, and how much time is going to take, so that they're well aware that, how much time we'll need to give this athlete or this child before the child can come back to training. For example, I'll just give you an example. Say if you have an overuse injury of any injury, and I feel that this is more of an overhead injury. So I don't allow the child to do any overhead activity, say in tennis. So I allow them to just do mild forehands, controlled forehands, no match practice, but only controlled drills, and then how many balls they can hit, so that the training keeps on going. And then they can go ahead with the agility drills, and if it's a shoulder injury, uh, so on and so forth. So it's very important to have everybody on board when you're especially talking about overuse injuries, because it's all about load management. So now we talk about the common overuse injuries around the knees. The most common, because whether it's for running, is mainly the iliotibial band syndrome. I'm sure you'll be seeing a lot of that. Then you have the patellofemoral pain syndrome. I'm going to handle this one by one. I'm just listing them out. The patellar tendonitis, Osgood Schlatter disease, Synderglassen-Johansson syndrome, popliteus tendonitis, degenerative osteoarthritis also is there. Degenerative osteoarthritis, I'll just say generally, it occurs in slightly elderly people, or maybe after the age of 25, 26. But if you look at a training load, if somebody has been running from the age of 5. So degenerative osteoarthritis is one of the commonest I've seen when I was in the battalions, when I was seeing soldiers, because they were having an average mileage of 5 to 8 kilometers with almost no cushion shoes, with totally wrong running mechanics, because nobody is a runner. They've just joined the forces and they're made to run. And they run 5 kilometers, 10 kilometers, 20 kilometers, and then they're training the whole day with no proper adequate recovery. We've changed a lot of that now. We've started improving with the shoes and the surface and gradually conditioning and loading. But initially, it was because this, and most of the soldiers, they do a lot on running on the hard surfaces, on the roads, and on the parade ground where everything is hard, and they're doing drills, all the Sabdhan, Vishram, and wearing then heavy shoes. One is they wear almost patla. If you've seen those army kind of shoes that we used to have previously, is that sherry colored or brown colored canvas shoes. I think the elderly, those who are above the age of 35, 40 maybe can understand. When you were in school, we used to give in this very thin pitty shoes, and then you run on the ground, and soldiers need to continuously run. And then immediately they change into those very heavy boots, niche jisme kheel laga hua hai, and they're doing Sabdhan and Vishram and marching and doing the drills continuously. So that's where you have all the overuse injuries, stress fractures. Okay, so the history normally tells you what the issue is, and once you have the history and the diagnosis, I think it's pretty easy to manage. You must be wondering what medial tibial MTSS is doing out here, but actually the medial tibial stress syndrome, we're always looking at the shaft, but sometimes we can have it slightly above, maybe at the upper 1/3 or almost at the condylar areas. So sometimes they can mimic the knee pain of maybe the soft tissues. But if you get an X-ray and then we find out that maybe an X-ray or a CT and we find out there's a stress fracture. So that also should be kept in mind. And when I started off, I said bursa is very important. We know, I think most of you understand what the bursa is, Dan. I like to explain the bursas as if you go to a village, you'll see that pani jo nikalte hain, Rajasthan mein bhi, I think a kuan hota hai, and then you have that pulley. So you'll see that jahan pe new pulley hoti hai, water comes out very nicely, very smooth. The rope comes out very nicely. And again, we look at the rope analogy. If the rope is smooth also. So, but over a period of time of use, what happens is if there's too much of use also, so the pulley mechanics, if the mechanics are wrong, so the pulley starts moving right and left, and then the rope gets a little bit teared around the area, it starts fraying at the sides. And then when pulling the water also becomes a little bit difficult because the pulley is a little bit moving. So I look at the bursa as the pulleys. So if the pulleys are a little bit wrong and it's overused, so you see the bursal inflammation, we all know. Bursa's inflammation can be very, very severe and very, very painful. So because it's supposed to reduce the friction between the, tendons and the bones. So the knees, if you look at it, we have almost 24 bursae around the knee joint. So the common ones are the subcutaneous prepatellar bursa. We have suprapatellar bursa, subcutaneous infrapatellar bursa, deep infrapatellar bursa, subsartorial preancillus bursa, and semimembranous bursa. And most of you, I think in your clinical experience, will always look at the patellar bursitis and the suprapatellar bursae and the infrapatellar bursitis is the commonest, especially if you see that the individual has been suddenly increasing the mileage in running or increasing the mileage in jumping. So you'll find that the bursas do get inflamed and patient comes with pain. And the prepatellar, most often it's injured or inflamed. So we come now to the IT band syndrome. Everybody has heard about it. I think everybody knows about it. So I'll just run a very quick brief on it. And it is the leading cause of lateral knee pain in long distance runners. There is a correlation between running biomechanics and its effect on the IT band. So, and with running, coming, we have this Fit India movement where we have freedom run and you'll have different running where the Ministry of Sports Ministry and Kiran Rijiju and all these international athletes are asking you to run every day and put it on a video. And it's already started. It was supposed to start from 15th of August. It's going on till 2nd of October. Besides India, running is coming now. People are taking to running because running is actually one sport where you don't need a partner. You don't need anybody. You can just get up and run. And once you are able to run, you all know you get the runner's high, you get endorphins. Once you start loving it, you tend to run. And then when you keep running with not having a previous experience of having good running biomechanics, and then you increase the load gradually, or you run because you need to post on social media that today I ran 5-10 kilometers, you are going to get a lot of patients on IT band. So you should know how to manage the IT band or even detect it early. So look at the injury rates. IT band syndrome accounts for approximately 10% of all running injuries. And females are twice more likely to develop ITBS than the males. Apart from runners, it can also reduce performance you see in cyclists, soccer players, field hockey players, basketball players, rowers, tennis players, and even boxers. Most of the boxers, understand when they, I have had a lot of cases where, when they boxers, especially when doing the uppercut and all, they rotate their knee a lot. And if the mechanics is a little bit wrong, you'll find out that normally they don't have any problems, but when they're getting on the ring, and you find out that they basically have an ITB syndrome or an IT band inflammation or a bursa or a tendinopathy. That's it. So again, why are people scratching on my screen? I'm going to stop share and reshare. I request people kindly don't fiddle. It happens, you like to touch it. Please don't fiddle because then it spoils the flow of the talk. And of course, it will be your time that is going to be wasted. So we look at the pathophysiology. The pain is caused by excessive friction of the distal IT band over the lateral epicondylar femur due to repetitive flexion and extension movement of the knee. We are not going to talk about the upper structure because today we are discussing only about the overuse injuries around the knee joint. Presence of a maximal impingement zone found at or slightly below 30 degrees of knee flexion during foot strike, and the early stance phase of running lead to excessive compression of a richly vascularized and innervated layer of fat present between iliotibial band and the lateral femoral condyle. Okay, this was Fredrickson and Wolf in 2005. Clinical presentation, of course, you're going to see that they have an insidious onset, gradual, insidious onset of sharp pain on the lateral knee while running. The pain typically appears after running a few kilometers and increases in intensity with every mile, maybe even appear at rest. Physical activities that aggravate the symptoms include running downhill, taking long strides, or sitting with flexed knee or longer duration. Climbing downstairs also, they will complain of pain. Tenderness can be observed on palpation of the lateral knee approximately 2 centimeters above the joint line. You'll find a mild swelling with ITBs thickening at the lateral epicondyle. Palpation may reveal a sensation of wet leather crepitus. If you've had leather shoes or leather, just go on it and wet and just have a look. You'll feel that crepitus like that of rubbing a finger on say maybe a wet balloon or a wet leather crepitus that you can feel. So trigger points can be found in vastus lateralis, gluteus medius, and biceps femoris. Possible weakness of knee extensors, knee flexors, and hip abductors would be associated findings. So differential diagnosis, of course, biceps femoris tendinopathy, lateral collateral ligament sprain, lateral meniscal tear, myofascial pain, patellofemoral stress syndrome, popliteal tendinopathy, degenerative joint disease, superior tibiofibular joint sprain, stress fracture, and referred pain from the lumbar spine is also a possibility. So you need to have a look out and just don't think because an individual is a runner or a cyclist and then straight away jump to ITB. Kindly keep the other things in mind and have a diagnosis, differential diagnosis ready too. And of course, I'll not go into this. I think all of you are very familiar with the test. Like we have the Nobel compression test and we have the Obus seems to be a favorite with everybody. But I'll just say, look at Nobel compression test, bring the subject into a supine line and flex the affected knee at 90 degrees. Apply pressure at approximately 1 to 2 centimeters above the lateral epicondyle, while simultaneously you're extending the knee. The test is considered positive if the patient complains of severe pain of the same intensity as their experience when running at around 30 degrees of knee flexion. The Rennie test. The Rennie test again asks the patient to stand on the affected leg with the unaffected leg either flexed at knee or simply you keep it in non-weight bearing. Instruct the patient to perform a single leg squat to 60-90 degrees flexion and then come up. You can always ask the patient to keep a support. Most people are not able to do a single neck flexion. Just keep a general support for balance and then come up. While the patient completes this task, palpate the distal ITB just above the lateral epicondyle. You repeat the test once more by applying compression force over the distal ITB. The presence of pain or the crepitus indicates a positive test. And Obus test, I think everybody does the Obus test. This is the most commonly used test actually. You also use it to assess the flexibility of the ITB. And I'll just run it through you. Position the patient in a side-lying position with the affected extremity facing upwards. Bend the affected knee to 90 degrees. Slowly abduct and extend the hip so that the knee is in line with the trunk. And then you start lowering the affected leg into adduction. The test is considered positive if the patient experiences difficulty adducting the leg and it remains in abducted position with associated lateral knee pain. It is important to know that all patients with iliotibial band syndrome test positive in Obus tests. Thus, always conducted with either Nobel or any test for a confirmatory diagnosis. So you can combine these three tests to confirm this diagnosis clinically. So the potential cause of IT band syndrome can be caused due to musculoskeletal impairment, training errors, biomechanical faults, like mentioned earlier in the earlier slides, and extrinsic factors like footwear, etc. Training errors, obviously, the less experienced runners, like I talked about, then suddenly they increase their mileage, and strength deficits are at an increased risk. And injury rates are usually higher in runners engaged in downhill or slow running due to reduced knee flexion angles commonly seen in these activities. Cross-training activities that include repetitive knee flexion like cycling can aggravate ITBS. Running on the same side of the cambered road in a common training error linked with ITBS. You tend to take one track and same side you keep on running. So that is another one of the issues. So the history, as you can see, history is very, very important. So you get these kind of history, you need to be on the lookout. And extrinsic factors would always be running in old shoes, hard shoes, can potentially increase tension in the ITB by altering the hip and knee angles. So always, whenever you examine such patients, please ask them to bring their running shoes, not just one. Whenever you ask them to bring the running shoes, this patient has a tendency to bring the best shoe that they have, or maybe something which they just purchased, but the cause of injury could have been another shoe which they were using. So just tell them, bring all your running shoes. Let me have a look. You have to understand also that it's a totally different subject, but most people buy shoes either because it's very popular in the market without looking at at the foot mechanics or their own foot anatomy, whether it's a flat foot, they have cavers or they have pronation. So it's a high arch knee or a flat foot, high arch. Sorry, what do you call it? High arch of the foot they have. So it's very important. Like, most people buy shoes simply because it's expensive, because it's fashionable. So I think when you have these people who are running for a long period of time, you will need to ask them to get all their shoes and then check which shoe actually works for them. Now, a lot of my cases, no matter how much you treat, if you don't fix the offending factor, they'll keep coming back to you. Or sometimes, like for us, me being in the forces, my patients come back to me if they're not recovering. But in most private practice, they just do doctor shopping or physio shopping. And then the Indian mentality is generally, today I'll take an opportunity also. If you find that the patient has any complaints about the previous doctor and shows a prescription or of the physio and this physio that only this, you say this at that point of time, I think you should never badmouth any of your colleagues, whether they are physios or doctors, any professional. It's always been my principle. Among friends, we know who's good, who's bad, theek hai. Oh, ragging type, we do it among friends. But I think when you're doing with patients and clients and other people, I feel we should never, raise a finger against any of our colleagues. No matter you find out the diagnosis was missed, maybe, you can always say at that point of time, maybe they saw you, or just ignore that comment and don't badmouth any of your colleagues. I take an opportunity to just say this because today you're badmouthing someone else. I think if we don't stand as colleagues, as say you sports physios or doctors, or you don't stand for each other, you've seen in this arena, public is not going to stand you. They're all ready. As long as they are dying, they're ready to cover us, and moment things are over, they're ready to hit us and beat us up. So please do not badmouth your colleagues. So like I said, see, if you find out that you have any problems with your, they will, I was on the fact that they will shop for new doctors and new thing. And maybe the work of all 3-4 people has been ongoing, and then the individual actually gets fixed after coming to the 4th one. So it's been probably a contribution of all the other 3 doctors or physios. But the idea is that, okay, what we need to do is, what did the other physio or the doctor do that I missed? So you just add on to it. And unless you find out that they've done something really wrong, you don't need to really point it out. All right, so let me go ahead now. So we look at biomechanical faults linked with IT band syndrome. The crossover gait. You have the crossover gait can often be due to weak hip abductors or excessive dynamic knee valgus. However, it can also be a technical fault done to reduce the net lateral movement of the body. Contralateral pelvic drop with increased ipsilateral trunk flexion. You have altered pelvis and trunk movement patterns are having been commonly linked with ITBS. Any weakness of the hip abductors leads to contralateral pelvic drop during the stance phase. The excessive drop creates a shift in the ground reaction forces, leading to increased knee varus movement and increased tensile strength. You see, it's on Zoom, it's going to be difficult for you to just go through it. All I can say in short to summarize that is, whenever you see a patient of ITB or a runner, or for that matter, any sport, just ensure the first thing is you try and treat the root cause. For that, you need to get the running shoes, look at the running mechanics, and ask them. What I do is I ask my patients to bring to make the running videos. If they can't make my running videos, luckily I have a sports medicine center where I have a running track. So I have a straight running track and I have the 400 meter, the Olympic size track, synthetic track in my just 10 meters from my center. So I always take them to the ground where I don't have that much of space. So I ask them to get a video so you understand the running mechanics, and also make them run on a treadmill. And remember, the treadmill running is always different because it's also governed by the treadmill. So if the individual is a treadmill runner, of course, ask them to make a video of the treadmill running. If they are running on the surface, ask them to make a video of the running surface and try and analyze that. This really helps in if you just improve the running muscles, if you try and strengthen and the running muscles, take care of the nutrition, recovery, and the running mechanics, your patients will recover pretty fast, and hopefully they will no longer have a re-injury. Basically, the worst is when the individual becomes okay after all your treatment, they go back to running, and once they start increasing load, they come back because of the wrong mechanics. Nothing wrong with the treatment. So just remember that. Now, musculoskeletal impairments linked with the ITBS could be the anatomical factors such as increased prominence of lateral femoral epicondyle and leg length differences, strength and flexibility deficits. Please check for leg length differences. It's not only for the ITB, but for all the knee issues. I learned this during post-graduation also. We tend to not check generally because when there are so many patients, we don't have the time. So if somebody is not recovering despite your best treatment, always call the patients in proper clothes and shorts, and measure the limb length difference for any discrepancy. And if the discrepancy is there, if you correct the discrepancy either mechanically or by adding the thing into the insole into the shoe, maybe it's going to help. Strength and flexibility deficits would be tightness in ITB or weakness in the gluteus medius. And in my personal experience also, I've seen that if there is uh, weakness in the glute med, or if the glute medius is not really firing or not really strong, this is also one of the factors. And when we fix this, actually the patient does improve. Increased hip abduction, adduction, and knee internal rotation is known to create the torsional strain in the ITB. So if there's somebody who's got a hip adduction and with a little bit of internal rotation, it's known to create a torsional strain in the ITB. Females tend to be at greater risk, of course, you all are well aware, due to the greater, the peak hip adduction angle owing to limited pelvic control in the frontal plane. So now we come to the management of IT band syndrome in runners. Acute phase, of course, the goal is always to reduce inflammation. Then, of course, activity modification and patient counseling is a must in this phase. We stop all the aggravating activities involving knee flexion and extension. However, cardiovascular fitness training can be continued swimming using only the arms and a pool boy. So what I do is I always like to put my patients on the pool if it's possible. Now, of course, because of COVID, we don't have the swimming pool, so you can go for alternative exercises, upper body. If they want to maintain the cardiovascular, you can put them on the rowing machine without excessive use of the knee. Don't let the knee bend more than 30 degrees, and just make them go for their rowing exercises, and no knee movement should be at the point of pain. So they should reduce the intensity also, but maintain the fitness levels. Of course, then use of concurrent therapies like eyes, phonophoresis or antiphoresis can be done to reduce pain and inflammation. Non-steroidal anti-inflammatory drugs may be recommended in a few cases. Oral non-steroidal anti-inflammatory medication is recommended. Corticosteroid injection if pain and visible swelling persists after, it says 3 days, but I would say after at least 2 weeks of the above treatment. This is a scientific which says 3 days. My clinical experience, I would say at least wait 1 or 2 weeks before just unnecessary given corticosteroid injection. Criteria to progress to next phase would be at least 2 weeks of pain-free, activity when they're climbing upstairs, going for the day-to-day activity, they're feeling no pain. At least 2 weeks pain-free, light walk, which is going to test run them, and then you do a gradual graded progression. And then at the subacute phase, the goal of this phase is to achieve flexibility in ITB, hip flexors and plantar flexors as a foundation to strength training without pain. So the ITB stretching and standing has been shown to be very effective. Variations includes, the arms at the sides, arm extending overhead, arms reaching diagonally downwards. Soft tissue mobilizations can also be done to reduce myofascial adhesions. Foam rolling can be used to relieve. All these things that I've written out here are all available on YouTube these days. You can just type the iliotibial band exercises, and there's so many different exercises they can very well show you. And you can actually share this with your patients with the YouTube. You can fix up, or you can make small videos of your own and then share it with your patients, so they do the stretching and the exercises correctly and the variations correctly. Of course, now then we come to the criteria to progress to the next phase. After that is, once the range of motion is regained and the myofascial restrictions are resolved, it is safe to progress to the next phase. So we start with the recovery strengthening phase. This phase aims at strengthening the gluteus medius muscle, including the multiplanar closed chain exercises with neuromuscular retraining. So open and closed chain exercises for the gluteus medius with and without resistance, segmental body weight, gravity, and resistant bands. And for patients with excessive knee varus Visual feedback can be used to reduce excessive knee external adduction moment during treadmill walking with verbal cues. And of course, after this, once they are able to perform strengthening exercise absolutely pain-free, we think in terms of returning to play or return to running. The return to running should be gradual, of course. Again, it's question of load. Just because they are better, that doesn't mean that they should start immediately. Then taking long distance or middle distance running. Always start slow, and they should start at an easy pace on a level surface. If the patient is able to tolerate it without pain, slowly increase the mileage. No cross training in the initial phases. In the first week of returning to play, run on alternate days, starting with easy sprints on a level surface. Incremental increases in running volume is recommended. And of course, you progress to agility exercises and sport-specific drills. Lastly, it is equally important to monitor and correct any contributing training errors. This is just a few pictures, slides, which I was talking about in the previous slide, which you can share with your patients. So next, we're going to talk about patellofemoral pain syndrome, again, which is one of the commonest. So patellofemoral pain syndrome, most commonly known as the runner's knee or the anterior knee pain syndrome. It is defined as pain occurring around or behind the patella that is aggravated by at least one activity that loads the patella during weight bearing on a flexed knee. The incidence of patellofemoral pain syndrome, again, is approximately 22 per 1,000 person, with women being more affected, 55% than men. Activities such as running, climbing stairs, jumping, squatting are known to aggravate patellofemoral pain syndrome because of increased joint loading with knee flexion and bending. The causative factors, again, we have the extrinsic and the intrinsic factors. So the extrinsic factor is primarily composed of ground reaction force, which is affected by body weight, speed of walking, type of walking surface, type of footwear used, frequency of joint loading and training volume, etc. And intrinsic, of course, is biomechanical faults such as the patellar maltracking, increased quadriceps angle, Q angle, lower extremity muscle weakness, quadriceps, hip abductors, and external rotators, delay activation of vastus medialis, inflexibility of the lower extremity, foot overpronation, or rear foot eversion. So we will just look at the factors affecting patellofemoral capacity. Just a minute. I'll just have a sip of water. Okay. So we look at the factors affecting patellofemoral. Okay, so we look at, should we start with maybe movement? We start with movement, you see here, femoral rotation, tibial rotation, pronation, degree of the knee flexion, surface area. And you look at strength would be quadriceps, knee extensor, strength, hip after acquiring the patellofemoral pain syndrome. Of course, genetics and BMI, patellar, trochlear groove variables, body mass index. Overweight people also have a little bit more tendency to develop this patellofemoral pain. And of course, psychosocial anxiety, depression, catastrophization, fear of movement, and of course, the preparation, level of the fitness, the acute chronic workload ratio, time spent developing capacity, etc. If you ever notice anybody who's been injured once with the knee, and then when you ask them to jump immediately, if you have not trained them with balance, proprioception, perturbation, so they have this anxiety, the depression, they're scared. They also say, "Sir, mujhe dar lagta hai. I am afraid to put my knee or use my knee to jump." And then that also spoils the other mechanics also. So it's very important for you to work on their confidence when you're at the same time while you're treating them also. Confidence of movement. So you need to work a little bit on agility, mobility, at the same time, work on the mental aspects too. Now, clinical presentation, we all know is, you can have bilateral or unilateral knee pain in or around that intensifies, Just a second, slide. Okay. When the knee is flexed during weight-bearing activities, climbing or squatting activity. And they have a feeling of giving way or slipping, which is due to muscular inhibition. And sometimes they gave a history as if there's an ACL tear. And in my personal experience, sometimes when you have patients who've got lax joints and then they give this kind of history, You get the anterior draw test positive, you get the pivot shift test almost positive. But here, additionally, there's pain. So I label them as grade 3 or grade 2 ACL2, and keep this as a secondary diagnosis. And when they come from an MRI, we find that the ACL is totally okay, but actually this is the main diagnosis given by the radiologist. So it's important to look at when they give you a feeling as giving way or slipping, which is due to a muscular inhibition. We have non-localized pain, and they often point their hand on the knee or circumcise the patella, referred to as a circle sign. Rising after long hours of sitting with knee flexion can give rise to a locking or catching sensation. This characteristic feature is referred to as the movie theater sign. Okay, so we look at the diagnostic value of physical examination maneuvers for patellofemoral pain syndrome. You have the Clark test, which is 39 to 48, specificity 67 to 75. And medial or lateral facet tenderness would be sensitivity is 92%, specificity 65, and pain during squatting 91% sensitivity, but 50% specificity. Patellar apprehension test. This is just a study which was done, and I just wanted to share this with you. And patellar tilt tests. If you can go to the YouTube of this, you can see. Those who are interested can take a screenshot and then go and check this out. Okay, so then we assess the patient's gait and posture. You have exaggerated lumbar lordosis, asymmetric hip height, foot overpronation, knee valgus, or atropic decreased muscle mass, quadriceps. Then, of course, you check for hamstring, knee flexor extensibility, co-contraction of the hamstrings and quadriceps causing increased forces on the joint during exercise. Of course, then you have to check the patient's footwear. For any knee issues or back issues, please check their footwear. Altering running biomechanics, excess wear patterns on the medial aspect of the shoe could suggest pronated foot. Change in training volume or frequency, history again, change in training or running surfaces. The biomechanical faults can be because of increased internal rotation of the femur, as you can see here, and facing medially squinting patella. And you have a step down or single leg squat test can also help in visualizing the knee valgus. Quadriceps angle again is measured as the angle. The Q angle is approximately 14 degrees in men and 17 degrees in women. An increased Q angle while walking can be associated with a mid-stance valgus thrust, which again can aggravate or be a contributing factor to the patellofemoral pain syndrome. And of course, you have increased tibial rotation. Tibial rotations are coupled with subtalar joint motion and has the potential of excessively loading the knee joint through transfer rotations. And you have subtalar pronation. We check the pronation of the foot. Excessive pronation of subtalar joint in the mid-stance phase of the gait cycle can be a contributing factor to anterior knee pain associated with patellofemoral pain syndrome. So you can see that this is around the area which they would have a lot of pain. Slide is hanging. Okay. Management, as always, active rest, avoid any exacerbating movements or activities, loading the knee joint in the initial 2 to 3 weeks. Exercise regimes could focus on the hip, trunk, and knee. Active stretching exercises. You have squats, ergometer, static quadriceps exercises, active leg raises, leg press, raising and lower limb climbing exercises, exercise to strengthen the hip abductors and trunk stabilizing exercise, including rectus abdominis. And of course, the exercises should be continued for 5 to 6 weeks. And in fact, we also suggest that once the patients become okay, or your athletes become okay, you should ask them to continue the strengthening or the exercises or the rehab exercises. Most of them, the moment they become okay in their movement out of your hands, they totally stop doing the rehab exercises. And that's when the pain recurs again. It's important to tell them to continue and in fact increase so that it will benefit them for all of their life. You see, for example, you have all these back pain patients, you give them all these back exercises, McKenzie's, whatever exercise you give them. Moment the back becomes okay, they kind of tend to stop doing the back exercises. And then they come back to you again with pain. Some patients are smart enough to understand, oh, it was because I stopped doing the exercises. Most patients don't understand. They go back to the old lifestyle, which actually caused the problem without doing the exercises, and then they come back. The same is with the knee. And of course, taping and foot orthotics improve the patellar maltracking in athletes temporarily and very individualistic response. I'll just come back. The taping. I'll just tell you that taping helps. Most of the research still tells us that brace doesn't help, taping doesn't help. But I think we need to do more studies on these, like, look at evidence-based medicine. Uh, like, we have a lot of patients in India, but most of them are not actually doing the research studies. But I think we should pick up, especially where the teaching institutes are, they should take up these studies, so that, especially for the Indian context, most of the tapes, again, they are with foreign tapes and foreign athletes and foreign patients. I think we should go and do some studies and ensure that whether we can talk whether the taping helps. But it does help. See, I am a player myself. I use a taping. I tape myself also wherever I can access. If it's required, I do temporarily. So I also suggest that for all physios, even sports medicine doctors, if you're taping, try taping on yourself too, or get someone to tape on you, and just use it, whatever taping that you're doing, and then you'd be able to explain to the patient or understand what the patient is feeling, what is the feedback. You get a very good feedback on yourself first. So most of the braces and the tapes that I use, I first use on myself, and I see whether it's going to restrict my movement, whether it's going to support my movement, or if I'm going to do this particular movement, does it really help? Then you can actually advise the patient and also understand what it is like to use a brace. Most people never use a brace in their life and just straight away give a brace to a patient. And when the patient comes back with all sorts of complaints and we're not able to understand, try doing it. It will really help. And of course, the McConnell taping, the tape applies a medially directed force to contract lateral patellar maltrocking, including the tilt, rotation, and shift. And foot orthotics can help correct the dynamic valgus secondary to pes pronatus and rear foot eversion. Now we'll come to patellar tendinopathy again, which is so common. We defined patellar tendinopathy, it was first referred to as the jumper's knee. You remember ITB? Was a runners, most of the runners have ITB, but we don't say it's a runner's knee. Runner's knee, again, was patellofemoral pain syndrome. It's called a runner's knee. This is called a patellar tendinopathy. It's called a jumper's knee because it was reported first in basketball, volleyball, and high, long, and triple jumps. And yes, I do get more frequency of this kind of patient from my jumpers. So the moment I ask them what sport, which sport, I'm able to, kind of lock down on the diagnosis just based on history. However, the condition also occurs in a lot of other sports people who change direction, and may occur in sports people who do not perform either jumping or changing direction. The term patellar tendinitis is a misnomer, as the pathology underlying this condition, is not an inflammatory tendinitis. It's more like tendinopathy. But like once again, I said, you may have a lot of people who are athletes who don't have this jumping, but suddenly the coach puts them on plyometrics. Table tennis player, suddenly the coach put them on plyometric drill. You have a new coach. The player, again, like I said, when you have that, when I showed you that the pyramid of how you increase, first you increase strength, then you go into plyo, but they think that doing plyo will increase the strength. I think it's reverse. We should increase the strength and think of doing plyo. So this is what happens for a lot of other sports when they suddenly, you're asked to do sand running, or especially plyometric drills you have, and do on the trampoline and all. That's when patients come to you with this history. So if you just take a proper history, you'll be able to kind of find out the diagnosis. Again, we'll come talk a little bit about the pathology. Repetitive eccentric load on the extensor tendons while jumping is believed to be the cause of quadriceps or patellar tendinopathy. Normal tendon would be wide and glistening. If you look at this picture that we put, this is the normal tendon. It's wide and glistening. Tight parallel collagen bars. The patellar tendinopathy, abnormal tissue adjacent to the lower pole of the patella, separated by a large amount of ground substance that gives them a disorganized and discontinuous appearance. These regions of tendon degeneration correspond with areas of increased signal on MRI and hypoechoic regions on the ultrasound. So few clinical features here, the activities involving jumping or changing direction, basketball, volleyball, think of any sports, climbing, jumping stairs, I told you, sudden plyometric exercises. Pain is usually around the inferior pole of the patella, aggravated by jumping and early to mid squat. Of course, you have generalized quadriceps wasting is what, if they've come after a long time, you'll see the generalized quadriceps wasting, or you'll find that the quadriceps is really very weak. And common inferior pole of patellar tendon attachment, the tenderness would be around that area. Occasionally, a distant attachment to the tibial tuberosity also can be there, and it's rarely in the mid tendon. Swelling is rare. Tendon may be increased in thickness. You don't find any clicks and clunks and crepitus. And occasionally, due to quadriceps inhibition, like in the same as the patellofemoral syndrome we talk about, a little bit of giveaway is something that you can find. Knee range of motion, of course, you have the usual normal, no pain with overpressure. But maybe if you try and just make them jump over small little hurdles, first on the normal leg and then the other leg, you would maybe get some pain and elicit the pain. Of course, quadriceps contraction and extension, some cases are very painful. You may have normal patellofemoral junction biomechanics and joint mechanics and in combined problem will have the signs. The vastus medialis obliquus may have generalized quadriceps weakness. Functional testing, decline squats aggravate pain, and the patellofemoral joint taping has less effect. Investigations, of course, ultrasound examination, MRI, the investigation of choice in patellar tendinopathy. Although these imaging modalities do not have 100% sensitivity and specificity for the condition, ultrasound Doppler examination to assess vascularity in and around the tendon is more sensitive than MRI. So if, like I discussed before, for testing, for imaging, these days, if you have really good dynamic ultrasound, they use different probes for musculoskeletal system. And if you have an experienced radiologist or an ultrasonologist, they're really able to give you a lot of information on this. And it's non-invasive, it's cheaper. See, even MRI, in our CGHS rates is 2,500, 3,000. And normal knee MRI costs around 8 to 10,000 for a normal cost. An ultrasound at my CGHS cost me around 600 rupees. And maybe it would go maximum to 1,200 or 1,500, which is again non-invasive. If there are a lot of patients with MRI or CT scan, it's very, those who are afraid of being claustrophobic. As physios and doctors, you're not experienced enough, you don't know this, and the patient is not able to get your test done, and they don't come back to you with the reports. But ultrasound is really safe, non-invasive. I think you have to find out in your area who is the expert, and this will initially give you. And then if you have a very good coordination with your radiologist, I always discuss my cases with the radiologist that I send the cases to, and I send them entire clinical diagnosis, my functional test, everything on paper, and then I discuss with them if they have the time, and they approach the patient, and if they require an MRI on CT to go further or any contrast studies, they just call me back and we say go ahead. So it's time for you guys also to think of looking for good radiologists whenever you want to send them for radiology, instead of just doing a formality and just advising a test, musculoskeletal, instead of the other like the other normal investigations that we do. So treatment, it takes again 3 to 6 months to recover, especially when it comes to the tendinopathy. If it's very acute, it's different. We're not talking acute here, we're talking about overuse. So overuse basically almost chronic. So it takes 3 to 6 months to recover. A patient with long-standing history may require 6 to 12 months to return pain-free to competition without recurrence. So it's always important to detect the diseases early. Activity modification assisted by biomechanical correction, progressive strengthening. After successful patellar tendon surgery, it takes between 6 to 12 months to return to full competitive sport. Sometimes we may require surgery. Conservative management of patellar tendinopathy requires appropriate strengthening and motor control exercises, load reduction, corrected biomechanical errors, and soft tissue therapy. Invasive treatments include injection with substances that either affect the vessels like sclerotherapy and polydocanol, or theoretically improve tendon repair, platelet-rich plasma, etc., or matrix structure, prolotherapy. Relative load reduction, modified activity, and biomechanical correction will still be the landmark areas for you to work on. So relative rest with reduced amount of jumping or sprinting or the total weekly training hours. Strengthening and correcting biomechanics to improve energy absorbing capacity of the limb should be directed at both the affected musculo-tendinous unit and the hip and the ankle. The ankle and calf are critical in absorbing the initial landing load that reduces the load transmitted to the knee. So the calf complex must function well to prevent more load than necessary transfer to the patellar tendon. So, cushion shoes, strengthening the ankles, ankle strengthening exercise, correcting the ankle mechanics. These all will be very important contributing factors for treatment. Better landing techniques can decrease patellar tendon load. Compared with flat foot landing, forefoot landing generates lower ground reaction forces, and if this technique is combined with a large range of hip or knee flexion, vertical ground reaction forces can be reduced by a further 25%. So all these small things. If you watch videos, I mean, most of you have seen videos, you've seen how somebody who's not athletic or a child, if you look at gymnasts and how they land, and you see a lot of people who on the YouTube videos nowadays, or even on TikTok before it was banned, like some people land so gracefully and they move as if they're floating on the ground. So the mechanics are correct. The center of gravity is so good. That's the reason why they don't have the injuries. But there are those people who have this very static toe and start-stop kind of movement. very not nice to look at, not graceful like they say to look at. These are the people who normally get injured, especially when doing a lot of jumping. So you need to improve the landing techniques. You'll be surprised that actually when some of my players are not able to do plyometrics and all, I actually send them for, when the parents ask me what to do, I send them for dance class. I tell them, go learn ballet. You learn ballet, you learn to be graceful, you learn to become nice, or learn, some dance movement where your physical activity will be there, your hand-eye coordination will be good. You will not be loading the patellofemoral joint. You will not be loading the tendon, the patellar tendon, but you'll be working on, the nice, graceful movements, and that is also going to help. A lot of children, parents who actually want to push their children to full-time sports, they can't think of doing anything else. So, but they can't play tennis, or they can't play badminton, or they can't do any other sport or right now. So you can always keep them moving and put them into something that will actually help them. So I shift them sometimes to another sport like swimming. I push them to dance, where it improves their strength. And of course, you continue with the upper body movements and control drills or control training. Of course, rehabilitation, which if there are a lot of physios out here, they know the exercise-based interventions such as squatting, isokinetics, and weights reduce the pain of patellar tendinopathy and soft tissue manipulation. So we look at timings, we look at 3 months, we look at strength and strength endurance. And activity would be hypertrophy and strengthening the affected muscles, focus attention on all anti-gravity muscles. From 3 to 6 months, we can start with power and speed endurance, weight bearing speed specific loads. And from 6 months onwards, you can combine with a sport related load and speed, and sport specific rehabilitation. Injection therapy, we've already talked about. PRP seems to be a hot favorite these days. Then you look at sclerosing injections with polydocanol, resulting in significant improvement in knee function, reduced pain. Corticosteroid injections have been compared to placebo, and corticosteroid improved symptoms so much so that all 12 athletes, when that study who had done, who had placebo injections, subsequently had corticosteroid injections. However, 50% of athletes in the corticosteroid group failed to recover and were referred to surgery. Surgery only after a thorough, high-quality, conservative program has failed, since surgery gave no significant results. Surgeons might advise patients that while symptomatic benefit is very likely, return to sport at the previous level cannot be guaranteed. So this was just some study which was put on the slide. But I'll just tell you that it doesn't really matter. A surgery, we say, fails, it's not because the surgeon was bad. The surgeon has done his job. I feel that after surgery, so the pre-operative rehab and the post-operative rehab are very important. So a surgeon, if he doesn't, sometimes I'll just say, okay, fine, the surgery wasn't good. But if the rehab is extremely good, unless the surgery was really bad, then he's not going to improve. But generally, for these kind of surgeries, they are not very complicated surgeries. The surgeon does a fantastic job, but the rehab has to be very important. And if the rehab also, it basically boils down to the rehab people knowing the biomechanics of the sport, biomechanics of the individual, and of course, loading. Even loading in terms of rehab, how to rehab. So I think the rehab is going to be very important. So there's a huge role that the physiotherapist can play here. We come to Osgood Schlatter, which is so common and is also a favorite exam question too. So as you can see in the picture here, we look at, this is a common, most common injury to the knee that you find at children, which I also have faced a lot. So I'll just talk about it. Osgood Schlatter lesion is an osteochondrosis that occurs at tibial tuberosity in girls and boys as they approach puberty. It is much more common among boys at about age 13, 15 years, but these age varied, and girls age about 10 to 12. I am currently, as of now, at an average, there's never a time for me when children come to me that I will not have at least 2 children with Osgood Schlatter. Always, because they have been so much overloaded, because now a lot of parents are pushing the children, especially in cities like Delhi and all, where children who have never really played sports and have been kept inside the house and playing only video games and normal, and suddenly they go to the coaches, they're put into things, they found out to be talented, and the coaches load them a lot, and then you find children coming with a lot of issues, especially Osgood Schlatter being one of them. So load management here again is the issue generally. It occurs from excessive traction on the soft apophysis of the tibial tuberosity by the powerful patellar tendon, and high levels of activity during a period of rapid growth, and is associated with change in the tendon. So this is the pathology. Signs and symptoms, of course, painful symptoms are often brought on by running, jumping, and other sports-related activities. In some cases, both knees have symptoms, although one knee may be worse than the other. Usually, of course, the dominant knee, if it's right-handed or left-handed, normally is or if it's a sport that makes you go left or go right. So it's like that. And knee pain and tenderness. That's why again history is so important. Knee pain and tenderness at the tibial tubercle, swelling at the tibial tubercle, tight muscles in front or back of the thigh. The enlarged inflamed tibial tubercle is nearly always tender when pressure is applied. So this is a few pictures. As we can see, a bump here, and you can see the apophysitis here. Okay, what are the risk factors? Osgood-Schlatter disease occurs during puberty, growth spurts. Age ranges differ by sex because girls enter puberty earlier than do boys. Osgood-Schlatter's disease typically occurs in boys aged 12 to 14 and girls aged 10 to 13. But I have had children in boys, especially even from the age of 9 to 10, some Osgood-Schlatter around 8 to 9 years of age too. And yes, literature says girls are lesser. So if I just give you my own personal experience, if I've seen 10 patients of Osgood-Schlatter, 8 or 9 would be boys and just 1 or 2 would be girls. In my experience of 10 years in sports medicine. So this is like in an average. So if I say that would come to not even 10%. So the research that others have done a lot of research, and so I would agree to this that boys are more common. And I think it's also because research is sometimes can be skewed because for every 10 boys that are playing on the ground, 2 girls will be playing on the ground. So again, I don't know if how much studies we can talk about. So if we have exactly 1,000 boys playing and 1,000 girls playing, and then we take out the history doing the same amount of workload, maybe the research can be a little bit more aligned. But as of now, this is a fact which I've come across with my personal observation. Sex, of course, we always said it's more common in boys. Again, here, see, they've written it, narrowing as more girls become involved with sports. The condition happens most often with sports that involve running, jumping, and swift changes in direction. So, Osgood-Schlatter, I'll tell you surprisingly, when a lot of foot movements are there, I have less footballers, but I've had a good amount of tennis players. I've got a good amount of badminton players. A couple of children who are in athletics. Surprisingly, I had more in basketball, yes. Volleyball, yes. Handball, yes. But surprisingly, with the amount of sports being played in football, the Osgood-Schlatter is lesser in football. Maybe for a number of reasons. I think one is probably because football is almost invariably played in softer surface, and gradually they increase, and normally they always play, the kids play with their own level of playing if they're under coaching. And I think that proper concept with the FIFA 11 and strengthening the calves and thighs and together, so maybe that could be the reason, without having a unilateral approach like only sports specific exercises are done in most sports. In football, a little bit of all-round exercises are done. So that could be a factor which I feel, but there's no research. I don't have any research thing on this. But it's just a personal observation over the years. These are the sports. So I'm just telling you, surprisingly, I was expecting with this, if you look at this, maybe football I should be having more, but my experience with footballers is a little bit less. And I see a lot of footballers, children's age group. The condition happens, I see a lot of football kids, but not with Osgood-Schlatter is what I'm trying to say. But yes, basketball, table tennis, surprisingly, tennis, badminton, basketball a lot, handball, volleyball a lot because a lot of jumping. I hope you got my point. So when you see your patients, please look around that side also. It'll probably give you a perspective on diagnosis and management. Flexibility, again, tightness in the quadricep muscles can increase the pull of the kneecap tendon on the growth plate at the top of the shin bone. So x-rays are the most specific. We all know for Osgood-Schlatter, you don't need to do anything else. Immediately you have a thing, just get an x-ray done and just get an lateral view of a digital x-ray, and this is what you're going to see. Treatment, of course, conservative management, limiting the exercise activity until a child can enjoy activity without discomfort or significant pain afterwards. We rest them from activity for several months, followed by a strength conditioning program. Strength exercise for quadriceps and hamstring muscles may help relieve pain and prevent the disease from returning. Non-steroidal anti-inflammatory drugs, sometimes, yes, you try and avoid, but the initial phase of treatment, maybe a week or 10 days, you may require, you add your vitamin D, you add your calcium, that would be important. Surgery is very rare. I have, in all my cases, I've not subjected one of my patients to surgery till date for Osgood-Schlatter. So all the patients have recovered well. Some have taken a bit more time, some have taken a little bit more time. It has got nothing to do with patient compliance. Like they listen to you, but sometimes patient takes a little bit more time. So as of now, in my personal experience, we've not had the need for surgery, from my personal experience. But literature says that there are cases where they did have to go for surgery. Okay, prognosis, if you can diagnose it early, manage it properly, the symptoms will completely disappear when a child completes the adolescent growth spurt, around 14 for girls and say 16 for boys. For this reason, surgery is rarely recommended, of course. However, the prominence of a tubercle will persist. We'll have that little bump. Complications is not common. If they occur, they might include chronic pain or localized swelling. Even after symptoms have resolved, the bony bump might remain on the shin bone just below the kneecap. This bump can persist to some degree, but it does usually interfere with knee function. In rare cases, it can cause the growth plate to be pulled off away from the shin bone. That's it, tibia tuberosity. Just a little bit on Sinding Larsen, because Sinding Larsen, there's just a difference we'll talk about. Sinding Larsen is here, Osgood-Schlatter is here. So it's just the infrapatellar pole. So the affects the inferior pole of the patella and the insertion of the patellar tendon. Tendon avulsion and later localized calcification commonly occur 10 to 13 years age of group. But Sinding Larsen is not so common. I see more of Osgood-Schlatter. I have not treated much of Sinding Larsen in my experience. So, of course, you see repetitive traction at the inferior pole of the patella is one of the causes. You have, during early adolescence, you see immature and chronic excessive traction leads to tendonitis. You have microavulsions at the proximal attachment, calcification and ossification at the junction of the inferior pole and patellar tendon. And of course, this would probably be the X-ray that you would see here. And clinical presentation would be anterior knee pain, gradual onset of several weeks or months, aggravated by jumping and running activities, localized pain over the inferior pole, no history of direct trauma. On palpation, point tenderness is elicited at the patellar tendon junction. And imaging, you will see a little bit of calcification and ossification at the patellar tendon junction is seen on plain films. This should be differentiated from bipartite patellar or patellar sleeve fracture. This is a benign condition, and of course, it results in no long-term complications. The athlete or the child should be allowed to participate in sports as tolerated because the pain is activity related. Some modification in activity level may be needed. In some cases, the recurrent pain may persist for 12 to 18 months before spontaneous resolution occurs. Because decreased flexibility of hamstrings is a common finding in many athletes, the regular hamstring stretch should be done. Acute painful episodes respond well to decreased activity. You have localized massage. You use NSAIDs for short-term, local injection of corticosteroids. Again, I think you should leave that to the orthopedician to decide whether the corticosteroid should be given or not, because it can cause tendon rupture. So how to prevent an overuse injury now? So how to prevent an overuse injury? We advise players and parents. This is the advice we'd like to give. Warm up, including stretching, and warm down, including stretching before and after exercise. Use proper equipment. We already discussed that. Jogging shoes for jogging, a racket that is the right size with a proper grip size, and strings strung to your level of play. For example, I'll just talk about, say, tennis. So the tennis shoes that we use on synthetic surface, they're very hard, the shoes. And you see these children using the same thing for the fitness drills and for your jogging or running. So you have to be very careful that the shoes equipment should be correct. Like for example, hockey, you have the hockey track shoes or the football shoes. So when they're doing a normal training, they should use proper, say, cross trainer shoes or training shoes or gym shoes based on what activity they want to do. Same as with the rackets or the equipments. The pressure of the strings, if you're looking at other overuse injuries, here we're talking only about the knee. Increase the rate no faster than 10% per week. We're looking at increase load of training in terms of speed, in terms of power. Please don't, especially at the adolescent age, young age, do not go for more than 10% increase per week. And of course, the focus should always be on correct technique. And you always encourage the children that if you do a correct technique, you look at, say, for example, Roger Federer's longevity, or a lot of good players who have a very good technique are those people who play for a very, very long time. In badminton, look at Lin Dan. Look at his technique and the way he moves. It's like effortless. So when you see people who play effortless, they have a longer life. If you look at the history of injuries, much, much more lesser. If you pick up any athlete, unless we're talking about intrinsic and overuse injuries. So if the technique is correct, the chances of overuse injuries are less. Condition yourself means the player for 2 to 3 weeks before starting. This is what you have to tell the player and the coaches and the parents. Okay, listen to the body. Pain is a warning that something is wrong. Early identification and treatment will allow you to continue activity. Identify and correct the cause of pain or discomfort. Ensure full injury rehabilitation. That is, if you have a sore right leg, can cause an overuse injury the left through compensation. We discussed this earlier. So we come to the summary. What I want to summarize with this talk is overuse injuries occur because of repetitive and continuous stress. Children are uniquely predisposed to these problems. Knee is the most commonly affected joint. These injuries respond well to rest and holistic treatment. Early recognition, diagnosis, and management can shorten the recovery time, and maybe can prevent the child from losing a sporting career. And always prevention is the key. If you try and recognize, and especially those physiotherapists who are working in the field, who can recognize the training mechanics, always, if they can always learn the sport and guide the children in this, because even whatever we say, the physios are mostly more in numbers, and they are there in the ground. Like a doctor is not always in the ground, so the physio is there with the team, with the players, and there's more contact too compared to us. I think if you can talk to them, make them understand that the load management, the technique, the biomechanics are so important. And if you do this, we can prevent a lot of these overuse injuries. So it's all about load management. And of course, treatment is, we need a multidisciplinary approach. We can't say that Dr. Vikram is going to manage the patient alone. I'm going to manage the patient alone. The physio is going to manage the patient alone. We will need the biomechanics, the orthopedist, the podiatrist, the technical guys who do the gait analysis. And if you all work together, we can actually improve. And a lot of talented children actually are taken out of sports simply because they were mismanaged by the coaches and the parents, in terms of just giving them load. And because the concept is ki mehnat karoge to zyada mehnat to aur mehnat. I think you have to make them understand ki zyada mehnat nahi, is smart mehnat. Smart mehnat is very important. This would be my references. And if you see, most of the references were also noted at the bottom of the slides, where especially research articles were there. Karim Khan was my major source. Thank you all for your very patient hearing. I wish you all good luck for your career. I would like to thank Snehil, my sports physio here, who helped me with the slides, because Dr. Vikram initially gave me anatomy. Sir, you had given me anatomy and most of the knee joint injuries, and you told me not to touch ligaments and meniscus. So I had 84 slides were prepared for that. And 2 days ago, when I saw the chart, I saw it was overuse injuries. So I gave all the data and material, and Snail helped me in making the slides. And I managed to sit up the whole night yesterday and edit the slides to my liking.
Yeah, so nice of you. And
I hope it was useful. And actually, sir, the scope is more, but I've just taken the common injuries. There are so many more other injuries, but I felt that since the time was short, I felt that these are the common issues that we face. So thank you so much. And any questions? Once again, thank you, Snehil Khurana, my sports, for actually she made the base of the slides for me. I gave her materials. And so I was able to put up this decent presentation because of her. Thank you so much, sir.
Okay, so now we are open for the questions. So you can type in the chat box, and if you raise the hands, then we can unmute you also. So better would be you can type in the chat box, and then Dr. Ken can respond to that. So do we have any questions?
So this is the general problem in webinars. If it was a face-to-face,
yeah.
But anyways,
but
we have to do this.
Yeah, I have seen many hands raised and like many questions during.
Let me see, sir.
Yeah. In the chat box, if this is visible.
So no questions.
No, Athar wants to ask something. So yes, please type.
Hello, sir. My name is Atharva.
Mhm.
Yeah. Hello, sir. So basically, I'm a strength and conditioning coach. I'm currently preparing for CSCS, and I've been playing cricket for past 14 years.
What coach?
Strength and conditioning coach.
Okay, okay. You play any
I'm,
sports?
so I'm a cricketer. I'm a fast bowler,
Yeah.
but so
You
I
must have
have
mentioning your fast bowler, it's phase on or side on, huh?
yeah. I follow a lot Stefan Jones. So he's into that knee dominant, hip dominant bowler kind of different side on and front on.
Yeah. Please go on. I'm listening. I'm sorry I lost you, Atharva. I couldn't hear anything. Can you please repeat? You're mute. I don't know why.
Athar, we are not getting your voice, so
We're not getting your voice.
either you can type your question.
Hello. Yeah. Can you hear me, sir, now?
Yes, yes, yes.
Yeah, sorry. There's some issue. So my question was,
So I have hyperextension knees, and I've been through multiple ACL surgeries, and I've been through meniscus surgery. So how much does hyperextension knees affect all the other biomechanics? So my injuries are reoccurring, even though I am a certified coach. So I have been dealing with the isometric, eccentric trainings. I've done my proper rehab. I've done everything was asked for. But even though I'm suffering again and again from injuries, I don't know why, and it's mainly on the middle region and the ACL. These both are just, and especially on my right side, though my left side is
You are a right-hander, yeah, right dominant, left dominant.
right dominant.
So you're a fast bowler, or medium pacer, or spinner.
Yeah, so I've last bowled in 2 to 3 years ago. After
Yeah, you must
that,
have got
I've not
when
bowled.
you were playing, right? You must
Yeah,
have got
I was
injured.
when I was playing. Yeah. So when I was playing, I was around 19 years old, and that time I was touching around 125 to 130
Okay, that's good speed.
kilometers per hour.
That's good speed.
Yeah.
So that means your running also, how many meters was your running? 50, 60?
Around 20. So I had 20 strides, 18 to 20 strides.
That'd be around 30, 40 meters maybe.
No, sorry. Pardon me, sir. 15 strides. Yeah. 15 strides because I have not bowled for long. Sorry.
Yeah. So,
Yeah.
so if you're coming in with that much of speed with extension of the knee, obviously when you're landing, you know. So how did this ACL injury happen to you? Was it
So there are multiple reasons.
Yeah. When
So
did,
because of multiple reasons, these injuries just keep on happening. These injuries just kept happening. My first injury, so my left knee, left ACL has been operated once, and the meniscus
what
is so the
was the cause of injury in the ACL? It has to be traumatic. Can't
my
be over-
my both
Your
my
ACL.
ACLs have been operated. Both
Name,
my ACLs have been operated.
how and why?
I don't know, sir, because so the reason was not the same. Every time it happened because of the reasons. And my latest injury
Share with
was,
us.
pardon me, sir?
Can you share with us? Because ACL tear is always traumatic. It's not overuse.
Yeah.
It's normally traumatic.
Yeah. So it's a bit of a long story. So is it fine?
Yeah, go ahead. Because your experience will help everyone.
Yeah. So in 2012, I have been through my first ACL surgeries, first ACL surgery and medial meniscus on my left knee.
Yeah, I want to know the cause of the injury. What was the injury?
Cause of the injury, that's what I'm explaining. First time every time I fell, it's been while playing or doing some activity, not while driving or riding anything. It's happened on the field. My current surgery happened last year. That was my so एक बार ACL सर्जरी पहले हो चुका था राइट साइड का, लेकिन मेरा 2018 में मैं एनसीसी कैंप में था, तब मेरा मीडियल मेनिस्कस बकेट टेयर हो गया and the impact was so hard, my operated ACL फिर से lose हो गया.
Okay. So you had to go for a revision surgery.
Yeah.
You had to go for a revision surgery. Fine.
Yeah. और जो अभी का जो सर्जरी हुआ, रिसेंट सर्जरी जो हुआ, वो इतना थोड़ा सा कॉम्प्लिकेटेड हुआ क्योंकि वो उन्होंने पहले अचीलिस टेंडन निकाला, बट लेकिन वो शॉर्ट हो गया, इसलिए बाद में उनको माय फ्रंट लिगामेंट निकालना पड़ा, व्हिच इज आर द पीटी बैंड,
They took up.
वो
Normally
उनको निकालना पड़ा बाद में.
I know why they went for at least. The first one they taken that.
मेरा या पहली बार hamstring निकाल चुके थे वो, इसलिए they went with Achilles, but that came out short, so they went with the PT band. So आपको complication इतना हो गया है कि अभी फिर से like whenever I do अभी पता नहीं, like बहुत confusion हो गया है, I can't improve. सब हो चुका है, मैं isometric eccentric सब proper work कर रहा हूँ, लेकिन something when goes.
आप रहते कहाँ हो?
Sorry?
Where do you stay?
I'm from Kolhapur, but I shifted to Mumbai for my education.
Okay, I wish you were somewhere close to Jaipur.
Maharashtra, Kolhapur.
Because आपका केस हम Zoom में solve नहीं कर पाएंगे. But
I would like to visit, sir. I would like to visit, sir.
Vikram sir, would you like to take his questions?
Yeah, I want to. So this is very surprising. Surgeon has operated Achilles tendon.
Yes, sir.
If you can tell me the name of surgeon, because there are many less surgeons which take the Achilles.
His name is Deepak Joshi, Dr. Deepak Joshi from Kolhapur itself.
Deepak Joshi. Okay. So first thing is that we have a hyperextension. So whenever there is a hyperextension, the room for definitely is ACL injuries, because there is an impingement. Because that is the skiers also. When they deaccelerate, they put their knee like this. So whenever there's a hyperextension, impingement of the ACL. So we cannot change the bone alignment at this part of age. Whatever you can do is just that the hamstring strengthening, just to prevent ACL
balancing the muscles.
Yeah, the eccentric training of hamstring. Eccentric training of hamstring.
The quads, the hams, and goes even the gastrocnemius down to.
So that's what can at this point. And generally, when we go for surgery, the first choice is hamstring graft, followed by bone patella bone. So in your case, you do require a very strong graft. So bone patella bone graft is definitely preferred over any kind of Achilles or anything. So as of now, as you have operated twice, a revision ACL. So
twice ACL, and once it was meniscus. So my right knee has been operated thrice.
Sir, I think we will need to call him with all his records. It will make for a very interesting study for the next conference.
I would like to, sir. I would love to, sir.
Take care of the surgical aspects. I'll check all his biomechanics and everything, and then we'll work on him.
I would like to work with you. I would love to work with you, sir.
First.
Ken, there are many questions in the chat box. So
please go ahead, sir.
Yeah. So can you see these questions? So one is what is the
Can you perform strength training and FIFA 11 program on the same day? This is Girish. Okay, I'll take this question. Sir, FIFA 11 program is basically almost a warm-up program. So strength training is again like, you have to have a periodization of your training when you want to do strength, because whether you're doing strength or you're doing strength endurance or you're doing aerobic, anaerobic, you got to know what you plan to do. So that is very important. But FIFA 11 basically is warm-up exercises. The other thing that we like to reduce the knee injuries, especially the ACL, like sir also said, work on the hamstring. FIFA again has special those Nordic hamstring curl exercises that they do. Of course, don't jump someone straight away to a Nordic, otherwise he'll get a hamstring tear. You have to gradually increase the load and make them work initially with support, then slowly you let go, and then work on it. But FIFA 11 is on the day that before every match. But strength training is separate, where you want to plan for strength and conditioning. Okay, what is the next question?
So Ken, next is that what is the confirmatory clinical test for Sinding Larsen?
Sir, I think we'd like to do the squat, the test that we talked about. That will give you a slightly confirmatory test, but the clinical test basically.
Okay.
Provided you it can just mimic like patellofemoral syndrome a little bit. So we need to just rule that out. Okay, what is the...
Vikas Patel wants to ask
So
something.
I think we have answered that question.
And what this Bhairu Prajapati is asking, if ACL tier grade 3, then give.
So we can't give a PT management here. ACL, I'm going to talk for 2 hours.
This question itself is not appropriate.
And it's not overused, maybe. We're not talking about that.
Grade 3,
Prajapati.
grade 3 would always require a surgical intervention. In grade 1 and grade 2, if there's a not too much demand of knee, then you can try strengthening.
Sir, pre-operative rehab and post-operative rehab. And follow the proper protocols. You can go to Karim Khan. They have the entire protocols where you go from phase 0, phase 1, phase 2, phase 3, immediately post-op. You start initially with pain management, relief of pain, range of motion. Then you start gradually. So initially, my only advice would be don't rush post-surgery. Everybody wants to rush them to put them back to sport. No, respect the injury, respect the post-operative surgery. Like he said in that case, Atharva mentioned that revision surgery. Revision surgery, if your athlete, he may be world champion. If he's had a revision surgery, it takes 2 years to recover from a revision surgery, in my experience. Okay. So I think that the pre-operative rehab is very important, not to rush for surgery unless other complications are there, like a lateral corner injury, including with fractures. Others is a pure ACL. I think pre-operative rehab, plan the surgery well, and then post-surgery surgeon and like I said, the physiotherapist should be working together with the coach once you start return to play, and respect the injury. And initially when I started off, it was like I was thinking, no, I was so proud to get my patients back on the field 6 months. But I think with literature says that safely put him back on the ground, again depending on the sport, if it's explosive, 6 to 7 I mean, I think 9 months se pehle I should not put him in competition.
Yeah. So yeah, prehab is definitely very important. And all the questions regarding ACL and meniscus, we can talk tomorrow.
Yes, I think you are having a talk tomorrow, sir,
We
on
have
this.
talk tomorrow about all these traumatic injuries. After that, we have a ACL dedicated rehab that will be taken by Vaibhav Daga. And again, separate talk on return to sports. So I think all these questions can be.
Questions will be addressed.
And tomorrow again we are going to have the talk on ACL, meniscus, cartilage injuries, all the traumatic injuries. So the mechanism and the treatment option and everything. So we can meet tomorrow. If there's any other question to Ken, you're welcome. Is there any other question to Ken?
I don't see, sir.
Okay, Ken. Thank you. Thanks a lot for your time. I know you have taken time out of your busy schedule, and you have covered each and every aspect of this overuse injury itself, which is a very lengthy topic, and we can keep discussing on this for days. So
Yes,
this
sir.
is a truly lengthy topic, and you have prepared very nicely. So thanks a lot. And thanks guys for joining us. And very soon we will be sharing the YouTube link on your emails also. So see you guys tomorrow. Bye. Thank you. So we are
Okay, thank you so much, sir. And thank you everybody for a decent hearing. All right, sir.
Okay, bye. Thank
Have
you.
a good evening. Thank you so much.